This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Ariana Parks, physical therapist and your host, and today I'm interviewing Dr. Rebekah Griffith about practicing at the top of scope as a physical therapist in the emergency department. We will talk about the responsibilities of a PT and the type of patients you see in the setting, how the triage system works and the role of the PT in the process, the advantages of having a PT working in the emergency department, and how to start practicing as a ED-PT, and much more. Dr. Griffith is a physical therapist who specializes in the emergency department care. She is the founder of ED-PT, a business dedicated to enhancing and promoting the practice of emergency physical therapy. If you find this information valuable, please subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share with other clinicians who could benefit from this conversation. Thank you for tuning in, and we hope you enjoyed the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Systems for PT, the Do Anything Anytime EMR. Systems for PT develops systems for clinicians so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Sarah Health. Have you heard of remote therapeutic monitoring? Does it sound complicated and hard to implement at your practice? It doesn't have to be. Sarah Health is revolutionizing RTM, making it straightforward for your practice. From easy onboarding to hassle-free billing, they cover it all. Hi, Rebekah. Welcome to PT Pro Talk. How are you today?
I'm well, and you?
Very good. Thank you so much for coming up here, and let's get started talking a little bit about yourself and your background.
Sure. I'm Rebekah Griffith. I'm a physical therapist in the Denver metro area. I've been a PT for 15 years. I am a board-certified neurologic clinical specialist, and I'm also in a manual therapy fellowship program, which I hope to finish this year. Started my career in spinal cord injury and brain injury, and then some orthopedics, and then acute care. A lot of people kind of drift into acute care when they have families because it really works well with kind of some of that life-work balance. And then as part of that, I ended up practicing in the emergency department, which is really where I specialize now.
And that's what we want to talk more about. So what are the responsibilities of a PT in the emergency department?
Well, just like the responsibilities of a physical therapist anywhere, right? Like we're going to evaluate, treat, and manage those patients as best we can. So patients that come to the emergency department, if they were only coming for like life and limb threatening illnesses or injuries, maybe we wouldn't need to be there, but that's not the case. One of the number one reasons people go to the emergency department is for musculoskeletal injuries that are usually not serious. And some of that is patients just don't know where to go. Sometimes patients don't know if it's serious. Because it can feel very serious. So we treat a lot of that in the emergency department. Also vertigo, if you've ever woken up with a severe case of BPPV, you can understand why you might think that your life might be in jeopardy. It's scary, it's incapacitating. So we treat a lot of vertigo. And then if you think about our older adult population, and sometimes not just older adults, there's a lot of falls, there's a lot of failure to thrive, there are a lot of issues like that we get we get involved with. Kind of from a patient management perspective, is this patient safe to be at home? Can they return home? Do they maybe need a rehab placement before they go home? So that's kind of a high-level overview of what we do, but we work alongside physicians, nurse practitioners, PAs, nurses, medical students, residents, social work, case management, pharmacists. It's like the ultimate team sport in PT.
Very cool. And is it require any special training to work as a PT in the emergency department?
No, right now there isn't really any specialty training required, but what I would say, it requires certain skills and it requires a certain mindset and a certain level of tolerance that maybe other settings don't have. So if you really like predictability, that's not the place for you. If you like knowing what you're going to do tomorrow, also no. But if you're really interested in fast-paced, high stress, lots of variety, like really practicing at the top of your scope, it's absolutely someplace you should be. I usually tell people they need to have strong skill set because anything can walk through the door, whether it's a patient who is a child or it's a patient who's 106 years old, somebody with cystic fibrosis or someone with terminal cancer. It's not just outpatient orthopedics types diagnosis. It's not just vertigo. It's not just home safety. You really have to have a really broad skill set and understand the continuum of care so that you know where to get those patients next, and really have good communication skills so that you can work with that big team that I mentioned.
Yes, I just imagine how hard it, you have to know a little bit of everything because you never know what you're gonna see in that particular day. So how was that on your training, or how did you get to that point of maybe doing different types of specializations or studying a little bit of vertigo and then going to MSK, and then, just how did you get that level of knowledge in so many different areas? Because usually we decide, we're going to do manual therapy, outpatient, orthopedic, and we go all in. So how was that for you?
Well, I think one of my big soapboxes is that we need more PTs who are generalists and not just specialists. I absolutely love specialist PTs. We need you, but we also need PTs that specialize at being generalists. So there's that quote that's like, a jack of all trades is a master of none. But the full quote is, a jack of all trades is a master of none, but oftentimes better than a master of one. So you have this really diverse skill set. And I think some of how I came to acquire that was like I said, I started in brain and spinal cord injury, which is really specific. And I actually wish I hadn't done that. I wish I had started in a more general setting so that I had more of those skills to bring to those specific patients. So I almost feel like I did my patients a disservice by specializing super early. But also, if you've ever been an acute care therapist, you acquire so many skills because most therapists don't just practice on one unit. So when I started working in an acute care hospital, it's a large academic medical center. So I had to be able to practice in the ICU, and I had to be able to practice in the orthopedics unit and the cardiothoracic surgery unit. There were so many different demands that you just had to learn as you go. And that's part of why they have therapists rotate so frequently, so you can keep that skill set up. But as I started to work in the emergency department, there was a lot of failing forward. So I might not know what to do, and I'd reach out to a colleague where I would look something up. I still feel like I have to Google something every day, but I think the real key is not being afraid of that and finding where your knowledge gaps are and then just working to fill them.
Yes, that's very interesting. And then do you feel that this setting is limited to hospitals, or would be the same in urgent care? What is your thoughts on that?
Well, that's a great question. So there is a whole field of emergency PT that doesn't just include emergency departments. So there are PTs that are involved in disaster relief. There are PTs that are involved in the National Park Service, in wilderness medicine. A friend of mine works for the Department of Homeland Security doing disaster planning as a physical therapist. So that's it's such a broad field. And then I think of our sports PT colleagues who are doing sideline coverage. Those are also emergency PTs. Our physical therapists in the military are combat PTs. Those PTs are also providing those emergency PT services. So I think what they do is very different from what we do. They're very much first responders, whereas PTs in the ED are more of that first receiver. But I also think that we need to expand this model to urgent care. So I would love to see a physical therapist in every ED in urgent care, or at least have one be accessible by telehealth, because there's so much we can contribute. And I think there is a lot of support for this model, like in the workers' comp area, where people go to an urgent care for a workers' comp issue and often have physical therapists present. But really, again, much of what goes to urgent cares are physical therapy type patients. So I also encourage PTs who run outpatient clinics to provide some sort of digital triage to their patients so they can actually help us keep some of those patients out of the emergency department.
Yes, absolutely. That would be very, very good. And it's kind of like you're the first contact in many situations. And I think it should be more often than what it is right now, because I feel like it would be way more efficient right? Have someone there to triage, someone that specializes in musculoskeletal, that it's us, PT. So why do you feel like that's not more common than what it is today?
I think there's a few reasons. I think first, emergency physicians don't have a ton of exposure to physical therapists in their training. You know, if you're a neurologist, of course you know what a PT does. If you're an orthopedist, of course you work with PTs. If you're a pediatrician, you know what physical therapists do. But if you're an emergency medicine physician, maybe you don't know. So you don't know that whole scope of what a physical therapist can provide. Also, a lot of emergency departments really are measured on how fast they can move patients through. And there's this like incorrect perception that we will actually slow down the flow of care. Research has not borne that out. PTs can actually help improve operations in emergency departments because they're the right provider at the right time. So if we can see a patient, that frees the emergency physician up to see more emergent patients. It helps that patient get the care they need and not come back. It might decrease imaging, opioid use, improve follow-up to outpatient physical therapy services. And those are just the effects we know about. When I think about like early access to physical therapy, we know helps with low back pain, right? Like the research has shown that time and time again. If I see patients immediately after they hurt their back, and I can get them moving right away without fear and with confidence and set up this really great plan of care for them immediately, I would love to know what the downstream effects of that are to help keep those patients out of that like whole system of care or that delay of care. So I think the problem with it being not widely adopted is it's just hard to prove on a large scale at this point.
Mm-hmm. It would be good to collect a lot of data, like as you go, and then because it's something, it's not new, but it's still not as common as we think it should be. So just if you could call it, now we need our research colleagues to collect some data and do.
Yes, and there is good evidence out there. If you're looking for research about that, I have on my website a resource page of a list of over 100 references you can use to help start a practice in your hospital. But, I think we just also need to advocate more for what we do for our patients, and we need to help keep patients out of the emergency department so that they know they can go see a physical therapist before they would have to go to the ED. But I also think that's going to require a change in how physical therapists practice. Like, could you see a PT today if you wanted to, where you live? Maybe, but probably not. But I know I could find a chiropractor to see today. So until we can kind of become more available and accessible, I think it's going to continue to be an issue that will need to be addressed.
I think it's like an educational process. If you start being the first contact of people in the ED, and then they start to learn that they can go straight to the PT, they start talking about that with their friends and family, and then slowly you start to change the culture. As you said, when you think about chiropractor, you're gonna just call them and schedule a visit, and that's not the reality, I guess, for PTs still today to this day. So, who typically makes that decision to hire a PT to work in an ED?
Well, I mean, just as a credit to our profession, it's usually the physical therapists in the hospital. They might be getting calls to come down for a patient that they don't quite think is safe to go home. So they might be bouncing between the floor and the ED and trying to manage all of those different levels of care. So often it's a physical therapist that sees that there's a problem and then fights for change, whether that's through a quality improvement project, whether that's being present in the ED more often, demonstrating what kind of outcomes they can make. But usually it's a physical therapist who makes that decision. However, I talked to somebody today who was interested in learning more about how to start a practice, and it was a physician who was driving that for them because he had worked at a hospital in a different state with PTs and couldn't understand why there weren't any in this new state. So hopefully there'll be more change drivers that way as well.
And then the PT needs to talk. So let's say the PTs that are listening to us, they're working like a hospital, they should talk to the PTs that are responsible for the hospital, so they can talk to the, I don't know who would be the person in charge of making those decisions, but they would have to try to prove to them that's worth it to have PTs there.
Mm-hmm. Usually there's an emergency medicine medical director, and they are often your best champion. And the biggest secret that I tell PTs, if you want to get to practice in the emergency department, you need to know what the pain points are in your emergency department and then outline how physical therapy can help with that. So the pain point might be there are too many patients waiting for discharge because we don't think they're safe to go home. Okay, then we're going to focus on fall risk. It could be that they're having too many patients come back to the ED and they're all from musculoskeletal diagnosis. We can help with that. We're ordering too much imaging that's slowing everything down. Great, a physical therapist can help with that, and here's how. So really identifying what your hospital needs, because the emergency department is the gateway to your hospital. And helping solve some of those pressure points is the best way to start a practice in the emergency department, because we all know patient satisfaction and provider satisfaction goes up with a PT present. But if we can kind of show an impact on those other deliverables, that really helps make the program a little bit more longstanding and robust.
Yeah, if you can get all this data before you start the program and kind of direct to the needs of the hospital, and then show it later, the difference after you start working after a while, to prove the way that we can help.
Exactly.
And so how about the triage? How does it work? So if a patient walks into the hospital, how do the patient goes to you? How does that process work?
Well, I think it's a little bit different in every hospital. In my experience, many emergency departments have different zones. So one might have an observation unit and their PTs only see those patients. And those are the patients who can't quite be admitted to the hospital, but can't quite be discharged either. So a physical therapist might go and evaluate that patient and help with that discharge process. Other departments have like a fast track area where it's people who really probably should have gotten urgent care. They have more mild concerns. They have common musculoskeletal injuries. Oftentimes those patients will just be triaged very quickly to the physical therapist for further management. And then patients that are coming into the main ED, usually that comes in a referral system from the physicians who are managing that patient's care.
And then, so the ones that come to you refer to the physician. You're going to see them, you're going to assess them, educate them, give some exercise, and then you discharge them home, or depending on the case, you admit to the hospital. So like, how does it work, this path after you see the patient?
So our goal, just like every other person in the emergency department, is to get the patient out of the emergency department, right? Like we want to make you as better as we can and then get you out, whether that's to home, ideally, whether that's to skilled rehab, whether that's admitted to the hospital. So my assessment usually focuses on how can I help you right now with whatever symptoms that you're having, with whatever problem that you have. And then where am I going to send you next? Am I going to refer you to outpatient physical therapy? Am I going to set up home health physical therapy? Do you need to go to a skilled nursing facility because this is your fourth fall in the last week and you live alone? So making those discharge decisions is a huge part of what we do. And then when we're intervening with the patient, that might be something like manual therapy. It might be exercise. It might be gait training with a new assistive device. Anything. It could be vestibular maneuvers, whatever that patient might need. Sometimes it's just education. It's some of that pain neuroscience where we're educating patients about pain. We're telling them what to expect with their injury. We're letting them know how to self-manage and setting them up for success that way. But our goal is to get that patient out of the emergency department because they don't want to be there. That's not a good place to be. And we need to make sure that those resources are available for the next patient. So it's kind of like, I think of it like being in a train station. And then my job is to help get you on the right train as quickly as possible.
And I assume that varies a lot. Sometimes you would see the patient for 5 minutes and just educate them. And sometimes they would need like, I don't know, an hour-long treatment according to their needs.
Yeah, I think the longest I've spent with one patient is 3 hours. And then, there are other times you walk in and a patient doesn't want to see you at all. And it doesn't take any time at all. But sometimes it takes the longest amount of time just is explaining to the patient why we're going to see them. Because they might be like, oh, I think I'm having a stroke. I'm so dizzy. I can't even open my eyes. I don't want to do exercise with a physical therapist. So even educating the patient as to our role and what we have to offer them can sometimes take a little minute.
Especially if they are in the emergency, they are like, I need something.
Yes, they're not expecting it. It's unexpected.
Yes. Yeah. Do you have like a time constriction like is it constrict the amount of time that you are able to spend with each patient, or it depends on like if you have a lot of people coming in, you have to hurry up and you don't have that amount of time, like you said, 3 hours to spend with a patient? Does it vary according to the day? Like if you're super busy, then you just can see a patient for like 10, 15 minutes.
Yeah, it really depends. There's a lot of factors that you have to take into account. One is like the total volume in the emergency department. If we're having overcrowding and a patient is walking in and walking out, they might not see a physical therapist. We might just refer that patient directly to outpatient PT and not see them in the ED. So the way that I think about it is, again, from a triage perspective, our goal is to get patients out of the emergency department. So where is my time best spent? If I come into a room and a patient needs 3 people just to help them roll over because they're so frail or fragile, they can't stand, is anything I'm going to do in the next 20 minutes going to make a huge impact on that patient's ability to leave the hospital today? No, they need hydration, they need nutrition, they need medical management, and probably a referral to rehab. So I'm not going to spend as much time in that room. But if in the room next door, I have a patient screaming with mechanical low back pain, and if I spend an hour in there and that patient can stand up and walk out with a good plan of care, that's a better use of my time. So I don't really have a constraint with how much time I spend with each patient, but I try to think about the overall resources of the hospital and the overall needs of the patient. And how do I prioritize physical therapy for each one of them?
Okay, makes sense. And in your specific department, what are the biggest advantages that you see of having like PT on the emergency department? Like, do you all track numbers? Like, what is the biggest impact that you have there?
Oh, my favorite impact is patient satisfaction. Patients really love being able to see a physical therapist. When we've measured that in the past, it's been like 4.89 out of 5 on a patient satisfaction scale. Our providers love having us there to help provide the care that we do to our patients. We also help protect the hospital resources a little bit. If we can refer a patient directly to rehab and they don't need to be admitted to the hospital, that saves those resources for people in the community who are acutely ill and need that admission bed. Also, since COVID, there's been so much demand for hospital services. So sometimes our emergency department will have bed lock, where there are patients that need a room but can't get a room. So we might have people boarding in the emergency department for several days. The problem with that is there's not really a big mobility culture in the emergency department, right? So you might have an older adult that's getting delirious, that's not able to get up and walk to the bathroom by themselves. So having a physical therapist there to start that evaluation process sooner, rather than having that patient wait 3 days to get upstairs and then be evaluated by a physical therapist, also helps keep that patient's quality of care higher and helps expedite the discharge process for them. But for me, my favorite part is probably giving patients hope and the amount of change that we can see in one session. Like when you do an Epley maneuver on a patient and they feel like 80% better and they think you did some kind of witchcraft to make them better and they're so excited that now they can just walk out of the emergency department. I love that. Or when a patient has seen like 4 specialists and they can't figure out what's wrong with them, and you're the only one that's like found that pain. And they're like, oh, yep, it's right there. Like, what is that? It scares me. I don't know what to do. To be able to provide that patient education, I mean, that's my favorite part.
Very cool. And I just imagine like how you change the path of these patients to have this encounter early on and avoid all this long path, sitting just different types of treatments, trying to find the right resource for them. So it's just like that shortcut right there.
Well, and I'll tell you that sometimes that's my least favorite part is when we can't find the resources a patient needs. And that's the reality of the emergency department. The emergency department is a safety net, right? Like that's where everyone can go for care. And I love that because so much of our healthcare system is a luxury. And you can only participate if you can pay to play. But in the emergency department, we can help everyone. Maybe not the way we might want to, because resources are always a problem when we have payer-centered care. But if I can get a patient who needs something, what they need, if this is the only way they'll have access to a physical therapist, because they might not be insured, or they might not speak English, or they might not have, they might work two jobs and not be able to go to PT, whatever the case may be. I love being able to help those patients, but sometimes it just breaks my heart that we can't provide them the resources that they really need. And I think that sometimes can lead to a little bit of stress and burnout in ED-PTs is frequently knowing that there's more, but we can't get it for that patient.
Yeah. I mean, at least you are there trying to educate them and give the best that you can.
Yeah.
It's hard.
Sometimes it just doesn't feel like.
Yes. And how about imaging? So do you, like the PTs are the ones deciding that, or like if the patients, they pass through the physician first, the physicians decide that? So how does it work?
It's a little bit different in every ED-PT program because imaging regulations are different from state to state and hospital policies are different from hospital to hospital. So for example, in Colorado, PTs are able to order imaging. We are licensed to do so. But like facility rules in my facility do not allow us to do that. So it really just depends. So generally it's a collaborative discussion about whether or not, if we believe a patient needs imaging, I'll speak to the provider, whether that's a PA or an NP or a physician, and say, hey, this is why I think this patient needs this imaging. This is what I would recommend. I've never had trouble with that. I've never had a physician say no. Sometimes it just leads to a better conversation and they might say, actually, I think this might be more effective for what you're wanting to look at, or I considered that and ruled it out, and here's why. So I actually find that it leads to really good discussions, but ideally, I would like to see physical therapists being able to practice unrestricted at the top of their scope, regardless of the building that they're doing it in.
Yeah. And how is the acceptance of like physicians and other healthcare providers with your presence there? Because that is something that they're not used to for the most part.
Yeah, I think at our facility, we've had some kind of presence there for over 10 years. So we're really well valued and well respected. Definitely a collegial relationship. A lot of our physician partners will manage up for us and they'll say the doctor of physical therapy will see you next. They'll evaluate and treat you and set your plan of care. And that sets expectations for the patients. I have also had physicians say, I'm going to have you be the second opinion. And they'll say, Dr. Griffith is going to come and give you their opinion about your condition, whether that's a vertigo or that's a back pain. And so they really do treat us at that like high level, collegial level. They ask us for our input. If we say a patient's not safe to discharge home, I've never really had a physician push back. They say, great, tell us what we need to do next. So I find once you've demonstrated your knowledge, your capability, and your collaboration, it's almost always a really great relationship. The difference in the ED too is that the hierarchy is very lateral. The attending physician obviously is like the buck stops there with the plan of care, but emergency physicians are very used to using their resources. They're used to calling consults. They're used to talking to other specialists. They know what they know and they know what they don't know. And so they're usually very willing to collaborate. And I find it to be one of the most respectful places I've ever worked with other physicians, other medical providers.
That's very helpful that they are already helping you like with the patient. So the patients will also respect you because they are, talking about you and how you are going to provide care. And I think that's just halfway there because they first respect the physician. If you have this good relationship, just makes things way easier for PTs, right?
Yes. And I think sometimes it goes the other way too, right? Because PTs establish relationships with patients differently than physicians do. We have that opportunity to spend a little bit more time. We put our hands on patients. We ask different kind of questions. So I feel like patients really open up to us. So sometimes they'll tell us things they didn't tell the physician that I can go and pass on. Or sometimes they'll say, well, I don't really trust what the physician said. What do you think? And we'll be able to say, hey, that physician is exceptional. They have really great outcomes, really trust their judgment. And that helps give that patient some reassurance as well.
Yes, very good point. And do you have an idea of like how many PTs are practiced nationwide in the ED?
The most recent count that I've seen, it's kind of just manual tracking by a professor in Michigan, Dr. Stacy Fruth. She's trying to keep track of as many different practices as possible. And the last count was about 100. So it's, it sounds like a lot. But when you consider that that's like 2 per state, maybe that's not really anywhere near where I would like it to be. So if you're hearing this and you're practicing in the ED and you're not sure if you're being counted, please reach out. We'd love to get to know you and get to know where you're practicing so we can help providing resources to everybody who's practicing in the ED.
And how do you think that we can bring awareness to this topic between us, PTs, between the population? Do you have any suggestions?
Well, I'm doing the best I can trying to spread the word. It's my mission to make emergency PT well known and well practiced. So sharing case studies, presenting at conferences, collaborating with different hospitals, going in and consulting in different hospital systems. I think, too, if you're a patient and you go to the ED, asking, do you have a physical therapist that I can see while I'm here is a good way to get that patient advocacy going as well. As if you're an outpatient PT and you're listening, I would encourage you to reach out to your local hospitals because maybe your clinic can be somewhere those hospitals will send patients because we always need more outpatient places to send patients as well. So kind of connecting that way too and finding out what exists and what doesn't exist. I try to educate physicians as often as possible too because they really are in a position to help drive change within their own departments. So helping in those ways. There's also a lot of studies going on right now. There's some research going on at our hospital right now about falls in older adults. And the intervention includes a visit with a pharmacist and a physical therapist. So that's part of like how they're screening why these older adults are falling and what their outcomes are. And then there are some studies going on at Northwestern about algorithms for PTs to approach low back pain in the emergency department as well as vertigo. So as those things start to come out and more of that gets elevated on that national stage, I hope that we'll see some change.
Yes. And I know you have a business, right? The ED DPT. So what is that about?
So it's a business to help make emergency PT well known and well practiced. I also wrote a book about emergency PT practice and how to start that in your hospital. It's called Top of Scope, the Emergency Department Physical Therapist Handbook. And I have a podcast called In the ED Now to help ED PTs level up. So we talk to different specialists and then hopefully take those nuggets from different specialists that we can apply to help us build our tool set. Because as we talked about, we might see anything. So we need to have need to know a lot about a lot. And then we do consulting and continuing education also just to help people get started, get established, get going, and really just spread the word so more people are aware. I also love talking to students because if you don't know this career path exists, it's not going to continue to exist. So students, just trying to let them know that like those traditional options that we learn about in PT school, outpatient clinic, skilled rehab, inpatient hospital, there are so many options for you. Go to where the patients are, create your own niche. Your job might not even exist yet. There's so much opportunity in physical therapy.
Yes, that would be great to have these as an option, that you know that's another option, that sometimes you feel like you don't fit in anything or you like that environment or that, that it's not always the same thing. So that would be very good. Any resources that you recommend for people that want to learn more about this topic?
Yeah, for sure. So if you go to the APTA website and you look up Emergency Department Physical Therapy, there are a lot of good resources there. They've kind of curated some of the best literature there that you can read. There are going to be at least 3 or 4 different CSM presentations on emergency department PT this year. So going to that as well. And then there is a group, there's a group on Facebook, Emergency Physical Therapists, that you can join and connect with other PTs who practice in this setting around the world. And I have several resources on my website as well, www.theeddpt.com. And then there are also starting to be more and more international emergency physios. They've been ahead of the game on this for a lot longer than we have. So kind of looking at that globally is helpful as well. They definitely have a little more leeway in how they practice, a little bit differently than we do, but there's so many lessons to be learned across the world from different PTs doing this.
And what do you think would be a good advice to clinicians that are starting their careers?
Oh gosh. So don't decide today who you're going to be in your career. Like, keep an open mind. Being a physical therapist is that which a physical therapist does. So whatever you decide to do as a physical therapist, that's still physical therapy. You can do anything. And we need to get to more patients. Physical therapy shouldn't be a luxury. So think about how you can best serve. Think about how you want to serve. Don't just think about where can I work? Who can I work with? You can work with anyone, anywhere. And we need more of that mindset if we're going to continue to push our profession forward.
Very good. And before we wrap up, anything else that you want to add about everything that we just talked?
I think just that one of my favorite things about practicing in the emergency department is that concept of practicing at the top of your scope, using all of those skills and experiences you have to contribute to your patients. And that, I think, it's not a practice location, it's a mindset. So trying to think to yourself, what can I do to be top of scope today, wherever I am, wherever I'm practicing, and challenge yourself a little bit.
Yeah. And it's just, you got to be good at so many different things. So it requires a lot of work.
And wherever you are, right? Even if all you do is treat one very niche population, you still have to be at the top of your scope to do that. So I think that helps us with our lifelong learning. It helps keep us excited. It helps keep us engaged, and it helps our patients improve.
Absolutely. Rebekah, thank you so much for your time and for sharing your knowledge and your passion with us. And if people want to find you, I know you mentioned your website, anything, any other place that they can connect with you?
Definitely kind of on all different social media at the EDDPT on Instagram and Twitter and YouTube. The EDDPT is our channel. You can find some good resources there as well.
Awesome. Thank you so much for your time. We appreciate you coming here today.
Thank you so much.